Okay, everybody, we're going to go ahead and get started. I see it's at 2 o'clock Eastern Time. I'm Leslie Hamilton. I'm at the University of Tennessee Health Science Center College of Pharmacy, and I am the primary moderator today. And I'm so excited to have Catherine Donaldson, who is at the University of Chicago Medicine for her PGY2 in critical care, and Niti Shah, who is at Atlantic Health System as well, who are going to be presenting today. There are a few of you who are not muted, so if you wouldn't mind making sure that you're muted so that we can allow there not to be any interference with our presentations today. So I'm going to go ahead and stop sharing. And Catherine, if you want to go ahead and turn on your camera and get ready to start sharing your screen. We can see it perfectly, and you'll just put it, yep, looks great.
All right. Great, everyone. So thank you for that introduction. Again, my name is Catherine. I'm currently a PGY2 critical care pharmacy resident at the University of Chicago Medicine. And today I will be presenting on an article that's titled Safety and Tolerability of 23.4% Hypertonic Saline Administered over 2 to 5 minutes for the treatment of cerebral herniation and intracranial pressure elevation. I wanted to quickly do a little bit of pathophysiology on the disease state. So if you'll remember, the cranium is a fixed volume, and for most people, the average is about 1,700 mLs. And that volume is composed of 3 primary components, and those are the CSF volume, which comprises about 10%, the blood volume, which comprises another 10%, and the remainder is comprised by the brain tissue or brain parenchyma. Now, all 3 of these components ultimately exist in equilibrium with each other. And in theory, an increase in one component should result in a decrease in one or both of the components to maintain that consistent volume. Now, as you know, there are many etiologies that can ultimately throw this equilibrium off balance. So for example, there could be formation of lesions or tumors or abscesses. There can be things that increase the volume of the brain parenchyma, such as cerebral edema from things like acute hyponatremia or seizures. It can be an increase in CSF volume from things like hydrocephalus, or you can possibly have an increase in blood volume from things like traumatic brain injuries. Now, if you revisit the Monro-Cali doctrine, if you'll remember, the brain exists in this equilibrium, but when you enter in that mass, most of the time your brain is going to be able to compensate for those small masses. However, as that mass increases in size, your brain is unable to compensate by decreasing the other 3 components, and thus you start seeing raised intracranial pressures and resulting in low cerebral pressures. Now, the big concern and the thing that we're trying to prevent is in this bottom part of this picture, and that is brain herniation. And this is when your brain can no longer compensate, the ICP pressures are critically high, and ultimately this results in herniation of the brain parenchyma tissue. Now that brings into the importance of hyperosmolar therapies, so things like hypertonic saline. Now, if you remember, hypertonic saline works by creating that osmotic gradient, and this facilitates the shift of fluids from the intracellular space to the interstitial and intravascular space to allow for removal from the cranium and ultimately help decrease ICP pressures. Now, if you remember, hypertonic saline is generally given as an IV bolus. However, the ideal administration strategy has not been clearly established. 23.4% hypertonic saline is typically dosed as a 15 to 60 ml bolus, which is recommended to be given over a period of anywhere from 2 to 20 minutes. It is preferred to be given as via central venous access. However, there was a recent study that was published just last year that actually showed peripheral administration could be potentially safe and effective at reducing ICPs. Now, there is some considerations to keep in mind, and the primary one is going to be its high osmolarity. 23.4% hypertonic saline has an osmolarity of approximately 8,000 millimoles per liter. Now, there's 2 main concerns that come from this. The first one is going to be concern for infusion site reaction, so things like thrombophlebitis, injection site pain, and tissue necrosis. And that's why we prefer central venous access to be the preferred route that we administer this medication. The second big concern is concern for hemodynamic compromise, so things like hypotension and bradycardia. And this is thought to be related to the speed of which we administer this medication. I do just want to highlight a few studies of the previous literature, and this really is not an all-inclusive list, as you may know. However, I just wanted to highlight that in a variety of these studies, the administration rate that we give this medication over varies greatly. You'll see in this first study by that was published in 2005, they administered their 23.4% hypertonic saline over a period of 2 minutes. And then the rest of the studies vary all the way up to a period of 20 minutes. The other thing I want to highlight is that when safety outcomes were reported, they really varied, with some studies reporting no complications from hypertonic saline and others reporting things like hypotension, for example. There also was a poll that was actually posted on the NCS Twitter not too long ago, approximately about a year ago, and it asked how quickly you guys all administer 23.4% saline. And there was a variety of answers, with a majority of people saying over 10 minutes, but that varied between all the way up to 30 minutes, all the way down to an IV push. So we know that institutional protocols vary widely, and there's really no great guidance currently on the ideal administration time for this 23.4% hypertonic saline. That brings me to our study. So I wanted to give a little background on this institution and what really prompted this study to happen. So historically, this institution utilized IV syringe pumps to administer their hypertonic saline boluses over 10 minutes. However, the syringe pumps were ultimately retired at this institution, which prompted them to have a change in policy of how they were administering this 23.4% saline. Now, theoretically, the authors mentioned that administering this medication as a 2 to 5 minute IV push may be operationally advantageous in terms of it reduces preparation times for the medication. You need less materials to give it, such as IV tubing or pumps. And ultimately, the nurses spend less time administering the medication. So ultimately, what they did is they implemented this policy saying that their 23.4% hypertonic saline could be administered as an IV push over 2 to 5 minutes. And the purpose of this study was to evaluate the safety of administering this hypertonic saline when it was administered as that faster IV push. This study was a single center prospective observational analysis. It took place at Massachusetts General Hospital located in Boston in their emergency department and inpatient settings. The timeframe for the study took place between April 2021 and December 2021. And of note, this study was considered a quality improvement project, and thus they did not require IRB approval or informed consent for them to conduct this study. Ultimately, this institution ended up compounding pre-filled, ready-to-administer 60 ml Luer-Lock syringes, and each one of those syringes contained 30 mLs of the 23.4% hypertonic saline. Those syringes were then stored in the automated dispensing cabinets in their EDs and ICUs for quick access. And the labeling on these syringes contained instructions on the rate of administration that the medication should be given over. So in terms of patient enrollment, what would happen is during order verification, that pharmacist would intercept that order for 23.4% saline and would evaluate the patient for inclusion criteria and ultimately go to the bedside nurse and assist with instructions on how to monitor that patient, as well as follow up with those outcomes after the drug was administered. One of the big caveats to this is that this institution did not have 24-hour clinical pharmacist coverage and ultimately did not have a clinical pharmacist between the hours of 2200 to 0700 the next morning. In order to kind of compensate for this, they ran a report each morning to try and capture patients who could still be prospectively observed for safety outcomes within that 1 hour administration of the 23.4% saline. Ultimately, this resulted in inclusion criteria being at least one documented administration of the 23.4% hypertonic saline over the 2 to 5 minutes. And they were excluded if they were less than 18 years old, if safety data was not collected following the administration of the hypertonic saline, or if the sodium chloride was not administered over the pre-specified 2 to 5 minutes. Now, the primary outcome of this study was, of course, focusing on the safety of this. It was ultimately a composite of hypotension, bradycardia, and infusion site reactions within 60 minutes of the administration of the hypertonic saline. As a note, hypotension was defined as a systolic blood pressure less than 90 or a reduction in systolic blood pressure by 20 from their baseline. And bradycardia was defined as a heart rate less than or equal to 50 beats per minute. They also provided grading scales for the nurses to use in order to characterize these infusion site reactions, which I'll show you in just a moment. And then their secondary outcomes was trying to compare the highest and lowest SBP values before and after hypertonic saline was administered, as well as the comparison of lowest heart rate values documented before and after hypertonic saline was administered. This is a screenshot of the 2 infusion reaction grading scales that the nurses were provided to help grade those infusion site reactions should they have occurred. There's an infiltration scale that ranges from 0 to 4, 4 being the most severe, and a phlebitis scale also ranging from 0 to 4, with 4 being the most severe as well. Of note, I do want to point out that one of the key features behind these scales is the patient has to report pain, which I'll talk about why that's important toward the end of this lecture. In terms of their statistical analysis, the primary outcome was described using descriptive statistics alone, and the secondary outcomes used a mixed design ANOVA, and statistical significance was defined as a 2-sided p-value of less than 0.05. So overall, there were 40 total patients who received 23.4% hypertonic saline during the study period that they were looking at. Ultimately, there were 9 patients that were excluded due to being outside of the timing of clinical pharmacy coverage, which resulted in 13 total administrations being excluded. And then 1 patient was excluded due to hypertonic saline not being administered over the 2 to 5 minutes as previously indicated. Ultimately, this resulted in a final analysis, including 32 total patients. These were the baseline characteristics that were provided. So overall, there were 79 total administrations with these 32 patients that were included. The average age was around mid-50s with an average rate of around 70 kilos, and less than half of the patients were female in this study. And next brings us to our result table. So overall, again, there were 79 total administrations, with 62 of those administrations being given via a central line. When looking at the study's composite primary outcome of hypotension, bradycardia, and infusion site reactions, you'll see that there was 15% of total administrations that had that primary outcome resulted. When you break the composite outcome down into its individual components, starting with hypotension, a systolic blood pressure decrease of at least 20 millimeters of mercury from baseline resulted in 6% of total administrations. This actually comprised a total of 4 patients, and the authors did mention that all of these patients had potential exacerbating factors, and they listed things like uptitrations of propofol, dexmedetomidine, and or nicardipine as potential reasons that this may have occurred in these patients. In terms of a systolic blood pressure less than 90, this occurred in 8% of the total administrations, which accounted for 5 total patients. The authors also did note that in these 5 patients, they were all on vasopressor support therapy prior to the administration of the hypertonic saline. When you look at bradycardia, there was only 1 incidence that occurred. And they do mention that this 1 patient where this occurred in, there was no intervention that was required to correct it. And then finally, looking at our infusion site reactions, there was only 1 occurrence of this that took place in a patient who received it via peripheral line. And the only thing that this patient complained about was pain. However, there was no documented infusion site reaction. So things like thrombophlebitis, for example, that was documented when the patient did complain of this pain. In terms of their secondary outcomes, they were comparing pre-administration to post-administration and also broke down these values based on central and peripheral line, but ultimately found that there was no significant changes in the highest and lowest systolic blood pressures or lowest heart rate in the 60 minutes before or 60 minutes after the administration of hypertonic saline. So overall, the authors concluded that administration of 23.4% hypertonic saline as an IV push over 2 to 5 minutes is safe and associated with a low incidence of drug-related adverse events among total administrations. In terms of my critique of this study, I think there are several strengths and limitations that we have to keep in mind. The first strength is that this was a prospective designed study. The other thing is that clinical pharmacists were involved in enrolling these patients, providing bedside instructions for nurses for monitoring, as well as follow-up after the hypertonic saline administration. However, I do think this has a potential for entering bias into the study, but I'll talk about that in just a second. There was a clear description of hospital protocol and procedures to allow for implementation at other facilities, which I think is beneficial. So if another institution was wanting to implement something similar to this, they give a good outline of how they went about doing this for that institution to follow. And I also think that this study design does mirror real-life administration of hypertonic saline. I know a lot of the times we're telling these nurses to administer it over 10 or 15 minutes, but a lot of the times it's being given a lot faster than that, even when we're not intending it to. In terms of limitations, there were several administrations that ultimately were excluded from analysis due to being outside of the clinical pharmacist presence. There was a potential for bias, and I think this is because though it's a benefit that the clinical pharmacist was so heavily involved, I think that does enter some bias given that we're telling these nurses exactly what to look for, which I think is a little bit of an issue when you're thinking about monitoring a patient. The other thing is that patients are not always able to communicate pain or discomfort. So unfortunately, we don't have a lot of baseline characteristics to figure out who exactly these patients were or how really sick they were. But if you think about some of the patients you see who are requiring these hyperosmolar therapies, a lot of the time they may not be able to actually communicate pain or discomfort associated with this medication. As I just stated, the indications for hypertonic saline was not reported and there were minimal baseline characteristics. So it's really hard to actually apply this study to other patient populations since we know very little about the patient population in this study. There was a lack of statistical analysis of the primary outcome, meaning they only looked at descriptive statistics for their primary outcome and didn't have a comparator group. It was an overall small patient population, and I think it's important to keep a note that a majority of the administrations of this 23.4% hypertonic saline were via a central line, which could impact what outcomes we were actually seeing in these patients. So overall, I think this study does demonstrate that a faster administration of hypertonic saline as a 2 to 5 minute IV push may be safe. And we know that there are some operational benefits to utilizing IV push administration. However, I think it's important to keep in mind that this study has numerous limitations that impact our ability to really apply these findings to other patient populations. And I think the biggest thing is that it remains unclear if a particular administration strategy for hypertonic saline is superior to another in terms of clinical efficacy outcomes. So is it really necessary to administer hypertonic saline over 2 minutes? Is there any better clinical efficacy outcomes when we do it that way? I also want to point out that some institutions may have operational limitations to implementing a similar protocol, especially given the high-risk nature of hypertonic saline. And that brings me to the conclusion of my presentation. I'm happy to take any questions or comments at this point.
Catherine, thank you so much for a great presentation. And I don't see any questions in the chat yet, but I have a question or two for you that we can start with. So my first question is kind of what you do at your own institution. I noticed that these are stored in the automated dispensing cabinet, Omnicell, Pyxis, whatever people use. Is that something that you all do at your institution? And do you think that would be a hesitation some institutions may have in terms of storing it in those places?
Yeah, so I will start by saying what we do at our institution is we actually have the 30 ml vials that we store in our Omnicells to use. So in that perspective, we don't have any, pre-filled compounded syringes like this study did. However, given the high risk nature of this medication and even the authors in this study, there is always some hesitation of storing these types of medications in an Omnicell like that. However, I know in this study in particular, they did require a dual authorization for the nurse to pull this medication from their Omnicell, which I think is another safety measure that they utilize specifically in this study.
And one other question that I have as well is, do you think that it delayed administration of 23.4 if a pharmacist had to go to bedside to educate nurses? I mean, it's an emergent drug, so I didn't know if they mentioned that at all in the study in terms of delays from a pharmacist getting to bedside.
The study did not mention anything particular in terms of delay, and nor did they really provide any time about, time from door to administration time or anything like that. But just thinking about it, it could have potentially delayed therapy. I don't know the specifics about, how quickly the nurse gave this medication once the pharmacist verified it, if they waited for the pharmacist to come to bedside to give that sort of instruction and education to the nurse. I'm not entirely sure of, but potentially there could have been some delays in therapy with this.
Okay, and I've gotten a few questions in the chat. The first question is, why do you think central administration was a limitation? And this person's just wanting to clarify that the main point of the study was giving it via IV push versus it being given peripherally.
So in terms of the central line administration, generally speaking, I know that, side effects are typically less prevalent in patients where we're giving that hypertonic saline via central line as opposed to peripheral. So you have less of a risk of those like infusion site reactions, for example, with central lines. So when I mentioned that limitation, I think, if there was more balanced administrations between peripheral and central lines, would we have seen a difference in the adverse effects that we've seen in the population?
Okay. Next question is, aside from the fairly small patient population in the study, why do you not think that this is generalizable to critically ill patients who may need 23.4% saline?
So, I mean, in general, I think that, this study could be applicable, but just, given the fact that the baseline characteristics that I gave you on the slide was the sum total of the baseline characteristics that the study provided us. So we really do not know who these patients were, what they were coming in with, what type, if they were trauma, if they were some other sort of related injury that prompted the use of 23.4%. So just really not knowing exactly who these patients were and who it actually applies to. I think that's a big limitation in order to, apply this to other patient populations, especially since, the neuro patients that we see at different institutions vary widely depending on where you're at and what type of patients that you normally take care of. Hopefully that answered her question.
I think so, but I'll let them, if they can send me a message if it didn't. Okay, next comment about a great presentation. Do you have any thoughts on why this institution drew out hypertonic saline into a syringe so it was ready to administer versus a vial? Any sort of, and you may not have seen this, any sort of storage guidance in terms of the dispensing cabinet?
So one of the things that crossed my mind when I was reading how they made these pre-filled syringes is that, we do have vials, 30 ml vials of this 23.4% hypertonic saline, but I know recently there have been some shortage issues surrounding having the availability of those 30 ml vials. So given the fact that then they come in larger vial sizes and the risk of, having the appropriate dose drawn up, I think that's one of the big reasons that they went ahead and pre-made these pre-filled syringes to help mitigate that issue of having the nurse draw up a dose or, whatever the case may be. That would be my biggest theory behind that. As far as storage guidance, I'm not super familiar with the storage guidance surrounding how to store those in Pyxis or Omnicell, so I unfortunately am not sure on that one.
No problem. It sounds like they didn't really give you that information anyway, so no problem at all. And then I think make sure I got through all the questions. I think our last question is, do you think this finally puts to bed, basically kind of ends the discussion on giving 23.4% saline, giving it as a push?
I mean, I think with all of the limitations with this study, I would be hesitant to say like, yep, we can definitely give this 23.4% over 2 minutes for all patients in all situations. I would be hesitant to make that conclusion. But however, like I said, I think a lot of institutions are already kind of practicing like that. So I think it does add another piece of validation to how we are already giving this hypertonic saline. But I still think the big question remains of, is there a preferred way to really be administering this hypertonic saline in terms of clinical efficacy outcomes and ICP reduction?
And one more, do you think that this article changes your practice at your institution for 23.4%? So that's the first part of the question. The second part is, if it doesn't change your practice, what would you hope to see in future literature that hopefully will come out?
I think the big question that I still have, and I've kind of mentioned this a couple times, but I would have loved to see some sort of comparator group in this study. So what they were doing previously of giving it over 10 minutes versus what they were doing now, giving it over this IV push of 2 to 5 minutes. And did that impact other things? So like ICP reductions, for example, before I, routinely implemented this in practice at my particular institution. However, I also will say that this does give me a little bit of, I would say, ease of my mind of, when a nurse does give this over 5 minutes or 2 minutes or a quicker IV push than what's typically recommended at our institution, which is 15 minutes here. So.
And there's a comment that just got put in there about that this person's institution doesn't allow the nurse to give it bedside, which I think is interesting. Probably a great variation of all of our institutions. They use it as rescue for intracranial pressure. And if you have any thoughts about RN administration and whether, at least at your institution and what you've seen, have you seen an RN be able to give it without a provider present, or does the provider normally need to be there?
I have definitely seen it be given by an RN without a provider present. I know as part of our residency program, we do respond to all code strokes throughout the hospital, and there have been a couple instances where we've had to give hypertonic saline without a provider being present at bedside. Though I'll say most of the time those providers are, within an arm reach or on the way, or, will shortly be arriving. So that's an interesting thought. I never thought about that instance.
Yeah, I hadn't either, because we don't have to have a provider at bedside at my institution either. But, that's just shows you kind of differences in practice everywhere.
Yeah.
Well, Catherine, I think that wraps up. One other comment. This is just a comment that she wants to see more line gauges used for peripheral administration, especially if it's over 2 minutes. So I agree with that. So I don't see anything else in the chat. And Chris Morrison, I don't know if you saw his comment, Catherine, where he said, "Screw the vein, save the brain." And sounds like this is something that we could maybe even study as a group. So you did a fantastic job. Thank you so much for your presentation. And if you want to stop sharing your slides, and we'll let our second presenter go ahead and get ready. As she's getting her slides pulled up, I wanted to remind everybody to please mute yourselves if you're not already muted. I've tried to send some of you all messages, but that way we can try to keep disturbances to a minimum. I'm going to go ahead and mute myself, and then just make sure you're putting it into presenter mode, Niti, for your presentation.
Hey everyone, can you see me here?
We can see you and your slides. If you'll just put it in the presentation mode, we should be set to go.
Okay, sounds good. Okay, all good?
Looks perfect.
Okay, awesome. Hi, everyone. Thank you for joining me today. My name is Nidhi. I'm a PGY2 critical care pharmacy resident at Atlantic Health System in New Jersey. And today I'll be presenting my journal club on the effect of anti-seizure medication administration on mortality and early post-traumatic seizures in critically ill older adults with traumatic brain injury, or TBI. To start off with a brief background, as we know, acute symptomatic seizures can occur as a result of severe TBI, which is defined as a Glasgow Coma Score, or GCS, of 8 or less, of which early post-traumatic seizures are defined as seizures that occur within 7 days of injury. The incidence of these seizures is around 10%. However, the incidence of subclinical or electrographic seizures can be as high as 25%. Some of the risk factors for early post-traumatic seizures include patients who have a GCS of 10 or less, a linear or depressed skull fracture, penetrating head injury, subdural, epidural, or intracerebral hematoma, cortical contusion, and patients who have an age of 65 years or less. And the reason why we want to prevent these early post-traumatic seizures is because it has shown to be associated with worse outcomes, including chronic epilepsy, cognitive impairment, as well as increased mortality. So what do the guidelines recommend? The American Academy of Neurology guidelines from 2003 say that for adult patients with severe TBI, prophylaxis with phenytoin is effective in decreasing the risk of early post-traumatic seizures. And then more recently, the Brain Trauma Foundation guidelines from 2016 also recommend phenytoin to decrease the incidence of early post-traumatic seizures in severe TBI when the overall benefit is felt to outweigh the complications associated with such treatment. They do mention levetiracetam as it has been increasing in use and practice. However, at the time that the guidelines came out, there was not enough data for them to recommend for or against the use of levetiracetam. Anti-seizure medication administration has been studied in various randomized control trials as well as prospective and retrospective studies to prevent early post-traumatic seizures as well as mortality. The guideline recommendation to use phenytoin to prevent early post-traumatic seizures actually comes from one of the main trials by Temkin in 1990, which was a randomized controlled trial of patients with severe TBI with a relatively young cohort with a mean age of the population, which was 34. They included around 400 patients and found that patients who received phenytoin actually had a decreased incidence of early post-traumatic seizures when compared to placebo, and this was statistically significant, and they found no difference in mortality. The same author conducted another trial in 1999 in patients with TBI and compared phenytoin to valproic acid and found no difference in either of the outcomes. Another prospective evaluation in 2013 looking at patients with severe TBI compared levetiracetam to phenytoin and found no difference in the outcomes as well. Another randomized controlled trial in 2016 looking at patients with moderate to severe TBI, again in the younger cohort, compared levetiracetam to phenytoin and found no difference in incidence of early post-traumatic seizures. And a retrospective cohort in 2019 that compared lacosamide to phenytoin also found no difference in the medications in reducing the incidence of early post-traumatic seizures. And lastly, there was a systematic review and meta-analysis by Watt in 2019 that included 3 randomized controlled trials. One of them was the one by Temkin in 1990, and also included 6 observational studies with a relatively young cohort of patients, and primarily studied phenytoin compared to placebo, or phenytoin versus no prophylaxis. And when they pulled all the results from the randomized control trials, they actually saw a trend towards a protective benefit with anti-seizure medication to reduce early post-traumatic seizures. However, that was not significant, as you can see from the wide confidence interval. When they pulled all the results from the observational studies, they found a significant trend of a protective benefit with anti-seizure medication versus no prophylaxis, and this was statistically significant, and they did not study mortality. So as you can see, while there's varying definitions, the current evidence is mainly in patients with severe TBI, include a younger patient population, and primarily study the efficacy outcome of preventing early post-traumatic seizures. Since then, in the past few decades, the landscape and the timeline of TBI or epidemiology of TBI has changed, and now adults over the age of 65 do have the highest rates of TBI-related hospitalizations. So this study looks at all severities of TBI. They primarily look at the older patient population, so age above 65, and look at the efficacy outcome of mortality. And the aim of this study was to see whether we can take these guideline recommendations and extrapolate it to the elderly population that is experiencing TBI. So this leads me to to our study that we'll be talking about today, looking at anti-seizure medication administration on mortality and early post-traumatic seizures in older patients with TBI. And this was a recent study published in the Neurocritical Care Journal in October. This was a retrospective cohort study. It used the Medical Information Mart for Intensive Care, or MIMIC, database that is available from MIT, and this is a publicly available data set. Looked at patients that were admitted to critical care units at Beth Israel Deaconess Medical Center from 2001 to 2012. They included all patients who had an age of above 65 years, and they were admitted to an ICU with a neurotraumatic diagnosis that included patients who had a skull vault or base fracture, mild, moderate, or severe TBI, cerebral contusion, traumatic subarachnoid hemorrhage, intracranial hemorrhage, subdural hematoma, and excluded patients who had a non-TBI primary ICD-9 diagnosis, patients who had admissions with incomplete drug information, patients who were transitioned to comfort measures only within the first 24 hours after admission, and patients who had seizures within the first 24 hours after admission as well. So patients either got no anti-seizure medication or they had anti-seizure medication administration within 24 hours of ICU admission. And they included patients who got any of these anti-seizure medications. So that includes patients with carbamazepine, lacosamide, levetiracetam, phenytoin, as well as valproic acid, amongst the others. The primary endpoint of this study was death within the first 7 days of admission to the ICU. And some secondary endpoints include looking at the incidence of early post-traumatic seizures, which was defined as having seizures within the first 7 days of admission to the ICU, as well as 30-day and 1-year mortality, and ICU and hospital length of stay. Our continuous variables were analyzed using the Wilcoxon rank sum test, and our categorical variables were analyzed using the chi-squared test. For our primary outcome, which was looking at the association between anti-seizure medication administration and the risk of death, the authors used a double robust inverse propensity scale weighted model. And really, this is a technique used to remove confounding variables and provide a more balanced model so we can get unbiased estimates of the average treatment effects. The secondary outcomes, so our incidence of early post-traumatic seizures, as well as our mortality, were more binary events. So they used odds ratios and 95% confidence intervals that were reported for 4 different logistic regression models, one being an unadjusted model, and then 3 different adjusted models, which were adjusted for confounding variables, one of them the most robust being the double robust inverse propensity scale weighted model. When we look at our patient enrollment, so there were 58,976 critical care admissions to Beth Israel, of which 1,353 were elderly neurotrauma patients. And when you exclude the patients who were transitioned to comfort measures, we had 1,169 elderly neurotrauma ICU patients. Patients who had a seizure within the first 24 hours were excluded, and at the end, we had 783 patients who received early anti-seizure medication and 362 patients who did not receive an anti-seizure medication. When looking at our baseline characteristics, you can see that the median age of the population was 81, and patients who received anti-seizure medication were younger in age, as of 80 versus 82. However, while this was statistically significant, it's unlikely to be clinically significant. Majority of our population was predominantly white, and there was an equal proportion of patients who were female and male. Most of our patients in the overall cohort had mild TBI, so 71% of our overall population. However, patients who had mild TBI were more likely to get no anti-seizure medication versus patients who had moderate to severe TBI were more likely to get anti-seizure medication, and this was statistically significant. And most patients were admitted with either a subdural hematoma followed by traumatic subarachnoid hemorrhage and cerebral contusion being the most common diagnoses. Looking at our other baseline characteristics, so they looked at Elixhauser-Van Baal-Raven, which is a comorbidity index that assigns a numerical score to look at in-hospital mortality, and they found no difference between the two groups. Patients who did receive anti-seizure medication had higher rates of mechanical ventilation, and there was no difference in patients who received a tracheostomy or gastrostomy feeding tube, as well as patients who needed vasopressor therapy. Of note, most patients in the overall cohort were prescribed phenytoin, so 74% of the population received phenytoin, around 22% of the population received levetiracetam, and a small subset of the population, around 2.5% of the patients received valproic acid. So when we look at our primary outcome, which was death within the first 7 days of admission, we can see that patients who received anti-seizure medication had a lower incidence of mortality, which was 5.2% versus 8.3% in patients who did not receive an anti-seizure medication. And this was statistically significant. Even when these outcomes were adjusted by the different models, so model 1 adjusted it for sex and age, model 2 adjusted it for different comorbidities and the severity of TBI, amongst others, and then our most robust one, which was the double robust inverse propensity scale model, the primary outcome still holds, where patients who received an anti-seizure medication did have a decreased mortality rate, and this was statistically significant. The authors provide a different way to look at our primary outcomes. So we can see this is the Cox proportional hazards regression model, or the Kaplan-Meier curve, showing the probability of death, which is lower in the anti-seizure medication group at all time points or all days within the first 7 days. And you can see this is statistically significant, and these lines do not intersect. When we move on to talk about our secondary outcome, first looking at seizure within the first 7 days of ICU admission, or early post-traumatic seizure, patients who actually received an anti-seizure medication had a higher rate of early post-traumatic seizure occurrence, and this was statistically significant, but this was the unadjusted model. When the authors adjusted it for the different confounding factors, especially in model 2 and the double robust model, they actually found no difference in the occurrence of early post-traumatic seizures between patients who received anti-seizure medication and between those who did not. Our other secondary outcomes include 30-day mortality and 1-year mortality, which was lower in patients who had or received anti-seizure medication, and this was statistically significant. And patients who received anti-seizure medication also had a longer ICU and hospital length of stay. The authors also provide outcomes, a forest plot of outcomes that are stratified by the severity of TBI. So I wanted you to draw your attention to model 2 and our double robust, which are our adjusted models. As you can see, patients who had moderate TBI actually had a trend towards benefit for the outcomes of death and death or seizure. And the authors provide an explanation, such as patients who had mild TBI may be unlikely to actually have these events occur, versus patients who had severe TBI may be too sick to actually benefit from anti-seizure medication. So while there was a trend towards benefit in moderate TBI patients for the outcomes of death and death or seizure, this was not statistically significant. As you can see, it crosses the line of no difference. And this could be because moderate TBI patients were such a small subset of the overall population, and most of the patients in the overall population did have mild TBI. So the authors concluded that anti-seizure medication administration to patients over the age of 65 within 24 hours of admission to an ICU after TBI is associated with a significant reduction in mortality at 7 days, 30 days, and at 1-year time points. And the mortality benefit that is seen with anti-seizure medication administration in elderly patients could be greatest in the moderate TBI population, as we saw with the forest plot. However, there was no significant association seen between early anti-seizure medication administration and a reduction in early post-traumatic seizures. So talking about some of the strengths and limitations of this study, I do believe one of the biggest strengths of this study is that it addresses an understudied population. So to my knowledge, this is the first study that is looking specifically at patients who are above the age of 65 and looking at prevention of or incidence of mortality and early post-traumatic seizures for TBI. Also, they had a very large sample size of above 1,000 patients, which is larger than previous studies. They did appropriately exclude patients who had a seizure within the first 24 hours of admission, and they did this because there would have been a lack of opportunity to give anti-seizure medication before they actually had the seizure, or there may be a lack of opportunity to actually reach therapeutic levels if they did receive the anti-seizure medication. And the outcomes were adjusted for confounding variables, as we saw with the different adjusted models. Some of the limitations of this study include the fact that this was a single center study, which can limit the generalizability of the study. And the data was limited to the ICU admissions. So we're not sure if patients had a seizure or received anti-seizure medication in the ED, for example, or we can't really know what the duration of anti-seizure medication was after they were discharged from the ICU. Also, the TBI severity was assessed by calculating the lowest GCS score within 24 hours of admission. So the Emergency Neurologic Life Support, or ENLS guidelines, actually mentioned to record the best observed GCS. So when we actually calculate the lowest GCS, we could be overestimating the severity of the TBI in the population. They did not report other sedatives like propofol or benzodiazepines that could alter the seizure threshold, and did not report any safety data for any of the anti-seizure medications as well. One other thing is that we're unable to account for all the subclinical seizures that could have occurred, as there is no report of patients being on continuous EEG monitoring to really differentiate between clinical versus subclinical seizures. So the way that the database reported outcomes was it was very binary. So either they had a presence or an absence of a seizure, and they did not differentiate whether it was clinical or subclinical. So we may be missing patients who did have subclinical seizures. We're also, while the authors did include patients who received all those different anti-seizure medications, we're unable to extrapolate data to other anti-seizure medications besides phenytoin and levetiracetam, as most of the patients in this population did receive phenytoin, about 74%, followed by levetiracetam, which was 22%. So overall, I do think this study provides good evidence for patients in an understudied population. Based on this study, I would consider administering anti-seizure medication to elderly patients that are presenting with moderate to severe TBI for 7 days, more to continue with the guideline recommended practice to administer anti-seizure medication as prophylaxis for patients with severe TBI, and then also adding moderate TBI to that recommendation, mainly because of what we saw as the mortality benefit, or at least a trend towards mortality benefit based on the subgroup analysis seen here. I would be more hesitant to administer anti-seizure medication in patients with mild TBI, as guidelines do not recommend this. And then also based on the study, while most of the patients did have mild TBI, when we saw in the forest plot, the mortality benefit did not seem to be driven by those patients who had mild TBI. And we're unable to attribute the mortality benefit with anti-seizure medication administration to a decrease in early post-traumatic seizure occurrence. So some thoughts on why we did not see a difference in early post-traumatic seizure occurrence. It could be potentially due to the fact that they excluded patients who had a seizure within the first 24 hours of admission. So when we exclude these patients, we could be removing the patients who are the sicker ones that are at highest risk for seizures and potentially weakening the effect of anti-seizure medication. Also, younger patients are at higher risk for early post-traumatic seizures. As we know, one of the biggest risk factors as provided by the guidelines is that patients who have an age of 65 years or less are at higher risk of early post-traumatic seizures, and this study specifically looked at patients who have an age of above 65. And there is a possibility that all of the subclinical seizures may not have been captured, and this could affect our results because, for example, patients with moderate TBI could have had more subclinical seizures that are missed if they were not on continuous video EEG monitoring. And lastly, it's important to consider that majority of these patients in these studies were on phenytoin. So I know, as we kind of mentioned, we've seen more levetiracetam being used, at least at our institution as well, and because of ease of administration and safety concerns. However, the differences in outcomes of phenytoin versus levetiracetam were not reported by this study. But based on the fact that previous literature has shown that levetiracetam is comparable to phenytoin, I would feel comfortable extrapolating this data to patients with levetiracetam. So overall, I do believe this study serves as a catalyst for future studies, but we still need those future studies to confirm the effect of anti-seizure medication administration on elderly patients and on the outcome of early post-traumatic seizures, and address if there is a mortality benefit, what is driving the mortality benefit if it's not the reduction in early post-traumatic seizures. So I thank you all for listening. That concludes my presentation, and I'd be happy to answer any questions.
Thank you so much for your presentation. And I'm going to ask a question first, and then we have at least one in the chat that I'll ask in a minute. I think you did a great job talking about basically 3/4 of the patient got phenytoin, and then about a fourth of them got levetiracetam. And obviously this was between 2001 and 2012. I think it's really interesting they did use valproic acid given some of the harm that's seen with valproic acid. But anyway, my question is for you. I mean, this has been maybe anywhere between 10 to 20 years ago in terms of practice. Besides drug therapy, do you think anything else, that may have affected our management of TBI patients that potentially also could have affected outcomes in this study?
I mean, it's possible depending on the type or the subtype of TBI that could have affected the outcomes in the study, or even, some of the more supportive measures like decompressive craniectomy, like your surgical decompression or ICP management, which has really, increased in use, and we've gotten a lot better with it. So those, other therapies definitely could have made a difference in our outcomes and led to the decreased mortality that we see, and not just the medications.
Okay, thank you. First question in the chat is, do you have thoughts on the use of phenytoin or valproic acid versus levetiracetam or lacosamide in elderly patients, since there's data out there about cognitive dysfunction, delayed recovery with phenytoin and valproic acid?
Yeah, so I'm not 100% sure on the data, but from what I do know with levetiracetam versus phenytoin, I know the efficacy was comparable with potentially better safety data in levetiracetam. I know there are cognitive effects. However, we would be using this. The idea would be to use it for only 7 days. I'm not sure when those neuropsych events that we are concerned about would occur, but I believe they can occur anywhere from immediately to later on in the course. So I know that can definitely be a concern, but we are using it. The idea is to use it for the first 7 days of therapy. So I would still feel that levetiracetam would be easier and safer to use in this population.
Okay, the next question, I'm going to ask it in 2 parts. There's 2 pieces of it. Did the authors comment on the either FOS or phenytoin dose recommendation, and if the patients achieved a specific goal?
So they actually did not provide any dosing at all. They really just said that majority of the patients were on phenytoin and then levetiracetam and then valproic acid, but there was no information on any dose or safety data.
Okay, the second part of the question is, what phenytoin or fosphenytoin dose would you recommend if you were getting to make that decision?
I believe the dose I would recommend would, well, if you have a load, this would be more for like status epilepticus, but I'm not 100% sure because I've only used phenytoin in a status epilepticus patient. So I would be more hesitant to give that big of a load on a patient who's, for what we're using it for prevention. However, I'm not 100% sure what dose I would recommend. I haven't had much practice with it, more for preventing early post-traumatic seizures.
That is totally okay. Those of us who've been in practice a little bit longer may have seen kind of when it made the transition. A very standard dose, at least I've seen, I don't know if other people have seen this, is just 100 TID.
I see.
Just kind of a standard
maintenance,
yeah, kind of a standard kind of maintenance dose.
Gotcha.
So then we got some tag on questions with that. A previous question is same thing about levetiracetam. And remember, this is not in status patients, this is prophylactic dosing. So do you have thoughts about dosing in this situation?
I believe there was a recent study that came out that actually looked at levetiracetam for seizures, and most places have been doing like 1 gram BID. And that's something that I've also been used to. So I think that potentially dose would be effective and safe for our patients with TBI.
I think you're going to see, I imagine some people might comment in the chat, a variation in practice because
Mhm.
I think some people probably use 500, some people use a gram BID.
Yeah.
So I think it can be quite varied.
Absolutely.
A kind of follow up in this population after a loading dose, I think you would have to think hard about dosing aggressively, thinking about 4 to 5 mg per kg per day after a loading dose for fosphenytoin. So that's just kind of a comment.
Yeah.
And then another comment right after that is something to consider is that TBI patients may need higher doses even in prophylaxis, given their volumes of distribution and clearance and those sorts of things. So yeah, absolutely.
Yeah,
I think you get 100 different answers if you probably ask 100 different ICU pharmacists. So it's interesting hearing kind of your perspective.
Yeah, that's a great point. Thank you for sharing.
Okay, I'm going to see if anyone else has any other questions. I see also in the chat just a comment that the Vmax isn't as high if it is like an 80-year-old patient. So it's a tough population for phenytoin overall. And I think people could also mention, even though this is not what your presentation was about the neuropsychiatric side effects of levetiracetam and just other things kind of to think about, especially in an older population. Did the new comment in the chat mention, did you see anything about renal dysfunction in these patients? Did they mention about dose adjusting or any sort of renal dysfunction?
No, they didn't. Like I said, they didn't really mention any dosing as well. They did have in the supplementary appendix, like talked about patients, or they stratified patients based on comorbidities. However, they did adjust for any comorbidities that they have with the model. So I wouldn't think that those like renal dysfunction patients would have really affected our outcomes, as they did adjust for those things. But no, they didn't provide any dosing anything. Yeah.
Do you, at your institution, recommend routine anti-seizure medicines in patients with a moderate TBI?
So that's something that I'm thinking of considering based on this study, though there are a lot of limitations that I saw with this study. But based on this study, I would potentially consider it as long as the benefits outweigh the risks in these patients, because it is a short period of time and it's for 7 days, and we are using it to prevent early post-traumatic seizures. I was surprised to see that the mortality benefit was being driven by the moderate TBI population when we saw the forest plot. And, it's hard to figure out what the mortality benefit is due to. Is it because, if it's not because they're helping in reducing early post-traumatic seizures, then what is the mortality benefit being attributed to? Because we don't have a lot of other information, but we can't ignore the fact that there was a 7-day mortality benefit as well. So I think I would definitely consider it, but I would want future studies to kind of confirm that recommendation.
Yes, and especially ones that are conducted with data that's been obtained more recently versus 2012 as well. And so just questions in the chat. These are just comments, not questions, comments about lacosamide maybe being a good option for elderly patients in seizure prophylaxis, especially since it's pretty recently become generic. And so just kind of in terms of thinking about cost and safety and stuff, might be something to poll our group to see what people think about that as well.
It's a great point. Yeah.
Okay, I think we have time maybe for one more question, and one just popped in the chat. So based on the PEACH trial, which I'm sure you have probably read before, that was in the ICH portion of that cohort, all seizures within the first 72 hours were electrographic seizures only. Are you still in support of the outcomes of the study presented, kind of given the results from the PEACH trial?
That's a great point. I mean, you said the outcomes were better in patients who had electrographic seizures. Just needed a reminder of the PEACH trial.
I'm going to pull it up myself and we can look at it together.
Let's see.
In terms of the... Abdallah, you can help us to remember about...
I can actually comment on this. I actually just read the PEACH trial not too long ago.
Perfect. Go for it, Catherine.
Yeah, so what they're saying is that in that study, seizures were only found by EEG monitoring. There were no clinically obvious seizures that were seen in that trial. So all of their outcomes were based on seizures that were only seen via EEG, and you would have otherwise not known that patient was having a seizure just because they didn't have like clinical seizures, if that makes sense.
Yeah, that makes sense. Thank you. Yeah, I think, well, based on that, it's really hard to extrapolate that data and compare it to this study, especially because we don't know how many of these patients actually had visible or clinical seizures versus those who did not, or they just had subclinical seizures. So I would want to know that information before being able to make, being able to make a decision on whether we could, use that data, because it is, completely different, and we're not sure how many patients in this study had those subclinical or electrographic seizures.
Absolutely. Thank you for answering. Thanks, Catherine, for jumping in too.
Thank you, Catherine. Yeah.
Okay, well, it is 3 o'clock Eastern time, so we are ready to wrap up. Thank you both so much for your presentation today and for everybody for attending. I hope everyone had a great trip, of everyone who went to mid-year, and has happy holidays and the holidays that are coming up in the next few weeks. So have a great rest of your afternoon, and thanks for coming today.
Thank you.